communication that we can use with any communication scenarios, like even when we talk to your colleagues or the doctors working with you, to your nurses. And today we'll be moving on to a little bit of more of difficult communication, where there were questions asked during last session that can we talk to patient? Is it okay to tell the patient? How will we talk to the patient about the diagnosis, the prognosis, or any bad news that they may not be wanting to hear. So today we'll be talking about communicating bad news as well as dealing with some of the difficult situations. Dr. Biju, yeah, welcome you, sir, for second session on communication, and thank you so much for joining.
Thank you, Sridevi. Thank you, Sri Priya, for having me. So we are short on time, and so welcome to all the delegates who are joining in from various parts of the country. Are there people from abroad also?
Yes, sir.
All right. So people from wherever, everywhere you are, and so as I said, without much ado, we'll start. So shall I start sharing?
Yes, sir, please.
So can you see the slide?
Yes, sir, we can see.
All right. So today we will be talking about advanced communication procedures, as I call them, because communication is not just random sitting and talking around. They are done for specific purpose and in a specific order to get an expected outcome. That's why it's called a procedure. So today we will be talking about communicating bad news, in which we'll talk about the various models that we have, and we'll also talk about why it is important to communicate bad news, the rationale for doing that. We will divert to collusion, what it is and how to manage it. Very, very short detour to collusion. From there, we will come back to communicating bad news. And this time we will talk about how to do it. We'll also have a small role play built into the presentation. And last, uh, a little bit about how to manage anger in our day-to-day professional life. So talking about breaking bad news, it is very difficult to do truth telling, especially if what we have to convey is something not nice. It is difficult to hear, it is difficult to say, but somebody has to do it. All over the world, there have been some standard models. For example, in our part of the world, if a patient and family comes into the doctor's room and the doctor has some bad news to deliver, the doctor would usually tell the patient to go out of the room and will inform the family, not the patient. So this would be a non-disclosure model because you are not disclosing to the patient. And we can have various well-meaning reasons for adopting this practice, because we are kind, we don't want to hurt the patient, etc., etc. The problem is that this model can get into conflict with a patient who wants to know. And people may want to know for various reasons. They may have the reasons for wanting to know. So this model of non-disclosure model gets into conflict if the patient wants to know, because the patient has the right to know. Another model which is practiced in some parts of the world is full disclosure model. That is, the patient is told everything about their disease, and the doctor can talk to the family only with the permission of the patient. These are the countries where they value patient autonomy. For them, patient autonomy is sacred. Such societies place a lot of value on individuals. So even if you want to tell the family member, you have to take the permission of the patient. In our culture, the family is more important than the individual. So you need to take the permission of the family to tell the patient. So in our culture, we usually practice non-disclosure model. There are some culture where you practice full disclosure model. And there's a problem when a conflict happens because a patient does not want to know. And just like a patient has the right to know, similarly, a patient has the right not to know. Now, these two prevalent models of non disclosure and full disclosure both have a problem because both can get into a conflict with the patient. And you have to understand that each individual has their own way of looking at it, have their own wants, have their own likes and dislikes. So we have to cater to the individual. And when it comes to communicating bad news, we have to have a individualized disclosure model. What is that? Essentially, you want to know whether the person sitting in front of you wants to know the bad news or not. And secondly, if the patient wants to know, then you have to figure out how much the patient wants to know, because you don't want to give too much of information and cause emotional injury, and you don't want to give too less information and create frustration for the patient. You want to give the right amount of information that the patient wants, not less, not more. So two things: find out whether patient wants to know or not, and if the patient does not want to know, do not proceed. If the patient wants to know, only then proceed, but give information, the quantity of information only as much as the patient wants. So now going into why bad news should be communicated at all. I give you three primary points. Two of them are on the slide right in front of you. First point is it gives the patient a chance to finish off whatever he or she needs to finish while there is life, while there is reasonable physical and mental health. So this could be related to finances, setting up a will. It could be giving instructions to the family members on how to proceed on whatever the matter might be. It might be about trying to do things that you always wanted to do but never found time for it. For example, a bucket list of things to do. Or you may want to strengthen the relationship that you have with your spouse, with your children, with your relatives, with uh, anybody else, your friends, with God, if you're religious. You may want to forgive somebody with whom you had a friction, or you may want to ask forgiveness if you have wronged somebody. So there are a lot of things you can do if you realize that you have limited time. But you can do all these things only if you realize it while you still have a little bit of health, physical and mental health remaining. If you're totally bedridden or unconscious or semi-conscious or, in that kind of a situation, it may not help. Another important area is hospital hopping and doctor shopping. This happens because patient and sometimes even the very close of the family members may not be aware of the diagnosis and or prognosis. Maybe the rest of the world knows, but the patient does not know, the patient's spouse may not know, something like that. So basically what happens is the patient's expectation is I am taking this treatment, I will get better, and I have a life to live. I have to go back to work. I have to get back to my normal life. Nobody told the patient the truth. Therefore, the patient's expectation, according to patient, are normal. According to us, it becomes unrealistic. So there is an expectation reality mismatch. And as a result, despite the best you can do for the patient, you will never reach the patient's expectation because they are far removed from reality. And eventually, the patient loses faith in you, loses faith in the institution, and demands to be taken somewhere else. The family cannot but comply. And this continues from one place to the other, and hence the term hospital hopping and doctor shopping. Essentially, going around from place to place looking for a cure which does not exist. This results in a lot of wastage of precious time, energy, effort, money, everything, especially time. When this person could have been, if the person knew, this person could have been at home enjoying his days or her days, trying to finish up or closing life's business instead of going around from place to place. A lot of financial ruin, especially in our country, happens because of pursuing futile medical interventions. A lot of people go into poverty. They lose everything that they have, including the house, the roof over their head. I've seen plenty of patients who had their home but now are in rented houses. When I go for home care, I see this. And when I asked, they said that everything was sold off because they were pursuing a treatment. And sadly, a lot of this could have been avoided only if timely communication could have been done. The other important point is this leads to a lot of barrier in relationship because the patient has not been told the truth. The family is forced to play act like a drama in front of the patient, put on a mask, behave as if everything is normal. Sometimes when they get overwhelmed with emotion, they may run to the bathroom, cry, and wash their face and come back in front of the patient with a mask on. So, where is the time for real relationship? Where is the opportunity to hug and cry? Where is the opportunity to hug and laugh? So, all of these things will not happen if the patient does not know. The family is forced to behave as if everything is normal, even though it is not. On the other side, the patient knows that something is terribly wrong. The patient's body tells him or her that I am not getting better. And the patient eventually realizes that the patient is not being told the truth. The patient understands that something is wrong. The patient may not understand that he has so and so disease, it is so and so stage. That the patient may not understand, but the patient definitely understand that something is terribly wrong. I am not getting better despite so and so. People are not telling me the truth. And as a result, the patient feels alone. Nobody's on my side. Nobody's willing to tell me the truth. And all of these things creates a lot of negative energy in the house because the patient starts getting angry at the family members. He or she resents the family members, says words which are very painful to the family members because the family members are working and doing the most possible for the patient, and in along with it they have to deal with their own grief. All of this creates a lot of negative energy. And finally, when the patient dies, what are the memories that the family have? A lot of negative memories. So only if the truth was told after the initial crying, there would have been definitely chances to make good memories that the family could have cherished for the rest of their life. Good memories for the patient while he or she was alive. A lot of positive energy, potential positive energy that was wasted by playing a drama when there was precious little time. So, because of these three primary reasons, the rationale why it is advocated that bad news should be communicated with the caveat that only to those who want to know, never to those who do not want to know. So now taking a deviation to collusion, many a times the family members, especially in our culture, come and tell us, doctor, please do not tell this to the patient. Basically, they are trying to get into a conspiracy of silence with us. They are saying that whatever information sharing, do it with us, do not do it with the patient. Now the family is doing this too because they love their person who is sick and they are trying to protect the patient from harm which they perceive will happen if the bad news is shared with the patient. Many times the family tells, oh, don't tell. The moment he hears it, he will immediately collapse and die. Some people say, don't tell her because she will go into depression and die. So a lot of people have a lot of conviction that this is what is going to happen. Now, when you challenge their belief, no, 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 this is not going to happen, they will get more scared. They will think that we have an agenda that we will be telling the patient. So already they are scared, and if we challenge their belief, they will get even more scared, and sometimes they may take the patient away from you to some other place because they don't want to take any chances. So to deal with this, it is better to agree to collude because you really don't have a choice. In our culture, you cannot overrule the family. So say, okay, no problem. In my practice, I ask them, so what should I tell? What have you told the patient? So if they say, "Oh, we have told him that it's an ulcer," I will say, okay, I will also call it an ulcer. And in this way, you reduce the family's anxiety. Now you're trying to palliate the family. Forget about the patient for the short while. By agreeing to collude, you reduce the family's anxiety. Now you have to earn the family's trust as well. For that, you have to listen to the family. You have to build up a relationship by practicing active listening skills that we talked about last time. And the best way of earning the family's trust is to relieve the patient's pain and other physical suffering. When you see your loved one relieved of suffering, it is easier to trust the doctor who made that happen. So use your palliative medical skills and relieve the patient's pain, breathlessness, restlessness, delirium, whatever it is. And once you have a happy patient, comfortable patient, you will have a trusting family. Once you have the trust of the family, now they will start listening to you. This is the time when you can reorient the family onto the benefits of communicating bad news, the benefits of telling the truth. So, primarily, 3 points that I told you earlier, these are the things that you can tell them. Not in the beginning, but at the stage where they have started trusting you. And once you have reoriented the family and with their permission, with their support, you can now communicate bad news to the patient. Initially, your success rate might be little, you know, not that great, but as you become more proficient in your communication skills, you will realize that your conversion rates progressively improves. But it is never going to be 100%. Even the best of the communicators will not have 100% conversion rates because there will always be families who will not be convinced and they will say, no, we don't want you to tell the patient. So, that case, do not push beyond a point because you don't want to create a friction with the family. So sometimes you have to be prepared for failure. That is, you failed in managing collusion. You failed in converting the family's point of view. You failed in reorienting the family. The family is still stuck with collusion. No, don't tell the patient. In that case, do not push beyond the point. Do not make it your agenda that you have to convert the family. So you can't tell the truth to the patient. That's okay. You can still do a lot of things for the patient because in any case you don't want to have a friction with the family because if you have friction, they may take the patient away or bad relationship with the family can get you into trouble even otherwise. So coming back to the how of communicating bad news, all over the world, the spikes protocol is what is followed. That's the standard operating procedure. The spikes protocol. That is an acronym for setting up the interview. You have to create the right kind of environment. And we'll talk about this in detail later. You have to assess the patient's perception. Basically, what does the patient understand about his or her situation? Obtain a invitation from the patient to have this conversation. And if the patient invites you, then you can share the knowledge and the information in a truthful manner. And naturally, expect emotions. You need to manage them. And then you can plan strategy and then summarize some of the things that we talked about in the previous session on active listening. So here is a small case. Mr. Bharat, who is a 60-year-old gentleman, he had an abdominal discomfort and weight loss about 2 months duration. He initially went to the local GP, who, after few uh, management and investigation, referred the patient as a gastroenterologist in the city hospital. Their CT abdomen showed a mass lesion in the stomach, and OGD biopsy showed a histopathology of CS stomach. An exploratory lab was done, which showed multiple peritoneal mets. The abdomen was closed, and the patient was referred to you for symptomatic or supportive care. So now the patient is sitting in front of you. So this is the reference letter. So within this few words, you have the entire story of the patient. But you have to hear the patient's story from the patient's mouth. So you take a history. So tell me what brings you here. I had gas since about 2 months. I went to the local doctor. He gave me some gas tablets. There was no relief. Then I went back to him and he took an x-ray of my stomach. After seeing the x-ray, he gave me a letter to see the gastro doctor in the city hospital. Okay, then what happened? Gastro doctor did a scan and a tube test, and then he told me that a surgery was needed. I did not have money at that time, so I went back to my village. And after 2 months, I managed to find enough money, and then they gave me a date, and then the surgery was done. Okay, then what happened? After the surgery, they gave me this letter and they told me to come and see you. So this is kind of a typical scenario that I've created in front of you. One is the referral letter, two is the patient story. But this story hides a lot of information. So if we practice active listening and dig more information, you will get more data from the patient. And the more information you have, the more power you have to manage the situation better. So there is another third story. This time I'm going to use some elements of active listening to find out, along with the story, what the patient understands, the patient's insight. So tell me what happened to you. I've had gas since about 2 months duration. I went to the nearby doctor. He gave me gas tablets. I took it for about 1 week. There was no relief. And then he took an X-ray of my stomach and gave me a letter. Wait, what was the X-ray? What was the result of the X-ray? I don't know the results. He saw this and gave me a letter to see the gastro doctor at the city. Okay, did he tell you why you were being referred to the gastro doctor? I think it was for better treatment. Okay, then what happened? So the gastro doctor did a scan and a tube test. Wait, what was the result of the scan? I don't know the result. They said something, but I don't know the result. Okay, then you said mention tube test. So why did they do the tube test and what was the result of the tube test? I don't know about this. They said that it has to be done. So it was a very, very distressing experience for me. So anyway, so they did this. And after that, they said that surgery has to be done. Okay. But I did not have any money at that time. So I went back to my village. And after 2 months, I found I managed to make money. They gave me a date and then the surgery was done. So how are you feeling after surgery? Well, after surgery, my gas problem is gone, but I'm feeling very tired. I'm always tired. Did I tell you uh, why you're feeling so tired? No, they gave me a letter to come and see you. Okay. Did they tell you why you are being referred to me? I think it's for better treatment. So when you ask more digging questions, you'll realize that the patient has a lot of blank spaces in his understanding. I don't know. I don't know. I don't know. So it is very important for you to, along with history taking, also take history of the patient's insight so that we have a clear mapping of what does the patient know, which is true, what does the patient think, which is not true, and what are the areas where the patient has no idea either way. Because when you later on try to give information, you have an idea which are the blank spots you need to fill and which are the wrong interpretation that you need to correct of the patient's understanding. So as part of spike protocol, initially you have to set the interview. In my case, I do a pre-procedure preparation, up to date yourself on the patient's medical condition, read up, and then allocate a dedicated time. In my case, I usually uh, keep in the late evening where most of my work is done. I have some time and also set the environment. I have enough chairs to sit in the room, water, drinking water, and tissues because usually there will be tears to wipe. So, some tissues at hand. And of course, practice active listening skills. So, to get the invitation from the patient, we have to first probe. There are some patients who may voluntarily ask, what is my problem, doctor? What is wrong with me? Tell me what is wrong. But in other patients, you may have to probe them to get a response. For example, Mr. Bharat, you told me you continue to feel tired. Do you wonder why? Do you want to know more about your disease? So it's kind of a probing, and the patient may respond, yes, I do want to know more about my disease. Now, this is not the point where you start telling the truth to the patient, because you have to be certain that this patient really wants to know. For that, you have to give a warning shot. Mr. Bharat, if it is something serious, would you still want to know? This will differentiate the first requirement of the individualized disclosure model, that you have to find out whether the person sitting in front of you really wants to know or does not want to know. So when you give a warning shot, if the response is something like that, no eye contact, the person is giving some excuses. For example, give me my medicines, I'll come back after 1 week. Or the person tells you, oh, tell it to my children, tell it to my spouse, or straight away tells you, I don't want to know. So if you have any or one or more of these reactions, body language or the usage of words, then that means this person is not mentally prepared to hear the bad news. This person has the right not to know. Do not proceed. Whereas if you see somebody like this, the body language is very clear. This person looks into your eyes and says, yes, no confusion. Only then proceed. So, warning shot clearly differentiates who wants to really know and who do not want to know. The other advantage of giving a warning shot is it creates the environment, the right kind of environment, the serious environment needed to communicate bad news. And how do you tell the bad news? Like you tell a story of the patient to the patient from the beginning. And while you're telling the story, you fill in the blanks with information, a small chunk of information at a time. And as you go, you escalate the intensity of the information. While you fill in the blanks, you gradually escalate the information. All the while, you focus on the body language of the patient. Body language is very important. Is there eye contact? Is there no eye contact? The moment there is no eye contact, you pause the story, because it's possible that the patient has got new information and is trying to digest the new information. You need some time. The patient may automatically come back and look at your face and say, okay, then what happened? So you can proceed the story. If there is a long pause and you don't know what to do, you can break that pause by asking, do you want to know more? Or some words to that effect. And if then the patient makes eye contact, nods the head, or say yes, then you can proceed. If the eye contact is not there, or if the patient makes eye contact and shows by body language, by shaking the head, that the person does not want to know anymore, then you stop the story where the patient wants the storytelling to be stopped. This way, you will be giving information only as much as the patient wants to know, not less, not more, just the optimum quantity that the patient wants. If the patient wants to hear the 100% of the story, you tell it to the end. So that is how you find out how much information to serve to the patient, one chunk at a time in a storytelling manner. For example, telling a story of Mr. Bharat to the patient. Mr. Bharat, you have been suffering from gas since about 2 months. Your local doctor gave you some gas medicines, but you did not get any relief from that, right? So he did an X-ray of your tummy, and the X-ray showed something like a shadow. And to know more about the shadow, he referred you to the city hospital. To see the wordings, something like a shadow in the next sentence is escalated to shadow. It is no longer something like a shadow. It is shadow. Oh, I didn't know that. Well, in the city hospital, they did a scan again of your tummy and it showed something like a tumor. And to know what this tumor was, they did the tube test, which is called endoscopy. So you can see while you're filling in the blanks, you are gradually escalating. Something like a shadow becomes a shadow, and the shadow becomes something like a tumor, and something like a tumor becomes a tumor. So you are gradually filling in the blanks and escalating the information as you're going along. Eye contact is there, so you proceed with the story. The tube test was done to see if your tumor was something like a cancer. Do you mean to say that I have cancer? I am sorry. Yes. Mr. Bharat, do you want to know more? They had operated and removed my cancer, didn't they, doctor? I'm sorry. When they opened up your tummy, they found the cancer had spread all over. They could not remove it. They just had to close your tummy back. They lied to me. Now the emotions are coming. The emotion can be in the form of tears or it can be anger. They lied to me. So whatever it is, whether it is tear or it is anger or stunned silence, whatever it is, they are all emotions. And when emotions are high, the rational part of the brain is not going to work. So don't try to say anything, don't try to soothe them, don't try to talk about what are the options here. You have to wait for the emotions to flow and subside. For that, just be with the patient. Don't start fiddling with your watch, don't start writing notes, don't do anything. Just be there, focusing on the patient. At best, you can touch the patient lightly for a few seconds and then take your hands off. Don't say anything. Whatever you say is not going to be of any use at this point of time. Don't do something. Don't say something. Just be there. This is the hardest thing for most medical practitioners because we are never taught not to do something. We are always taught to do something. Here we am suggesting or I'm saying, don't do anything, don't say anything. Just be there till the patient ventilates all the emotion. Once the patient calms down, or even during ventilation, it is possible that you may have to deal with some questions, especially questions which are said with a lot of emotion. How much time do I have, doctor? Now remember, there can be different reasons why people say what they say. And do not assume they are saying something for so and so reason. Ask them. Why do you ask that? Uh, Doctor, my daughter's marriage is fixed after 6 months. Should I prepone it? Should I arrange it earlier? Now, here is a person who asked that question, how much time do I have? Because this person wanted to plan. But the same question, how much time do I have, doctor? And you're asking, why do you ask that? Can have a totally different reaction. Why did God do this to me? So here is a patient who needs more ventilation. So you have 10 patients who say the same thing, how much time do I have? They may have 10 different reasons for saying the same thing. It's very important to understand that when people say something, especially with a lot of emotion, do not assume, ask. We talked about this in our previous session on active listening. Do not assume, ask, and they will tell you why they said whatever they said. Once you have sorted out all the emotions and all the emotional questions, and that now, once the patient is calm, it doesn't take long. But when you sit there, it seems like a long, long time, but usually it doesn't take long, few minutes at the most. Once that emotion has flowed away, the patient is now under control of their emotions. Now you can talk about what can be done, what cannot be done, etc. etc. And always be honest. Never give false hope. And you will learn in palliative care that there is no situation, absolutely no situation, where you cannot give realistic hope. Even if somebody is dying, there is a realistic hope that we will keep the person comfortable till the last breath of that person. What appears to be hopeless when we are not trained in palliative care, when you come into palliative care, you will realize there is always something to be done. But it is never false hope, it is always realistic hope that we give. So, with that, I stopped at the normal SOP of communicating bad news, but I realized there can be, especially in COVID times, we have to sometimes fast track communicating bad news. They may be paucity of time in ICU, in COVID ward, or ER, emergency, casualty, etc. So a few slides on communicating bad news in speed dial. First of all, you have to ensure that you do not botch up. So make sure you identify the family member correctly, because the patient is in a bad way. You have to convey something urgent to the family member. So you ensure that identification is correct. Are you the son of Mr. Bharat, hospital number 12345, who was admitted yesterday evening? Yes, doctor. How is he now? Despite all the efforts, he's deteriorating. I'm afraid he's not going to make it. Keep it short, keep it simple, keep it clear. Don't beat around the bush. But he was not this sick when he was admitted. I know it has been rapidly going down. The virus is really hard on him. I'm sorry. Despite all the efforts you made for him, he's sick. Now, this is something that I want to really focus your attention on. Despite all your effort, usually we end up saying, despite all that we did. So the point is, human psychology is always I centric. So when you say, as doctor, we did everything possible, the family is not interested in what you did. The family is worried whether they did the right thing, whether they did enough, whether they brought the patient in time, whether they spent enough money. All of those, their worry is that. So you assuage their concern, their worry, their anxiety, their fear by telling them you did the best for this patient, for your loved one. You really sacrificed a lot. You put in so much of effort. You did everything humanly possible for them. And you will realize that their anxiety, their anger especially comes down a lot when you tell them you did everything possible. But unfortunately, he's not. You really worked hard. You took him to all the right places. You brought him to the hospital on time. You spent money. You made so much of effort. Despite that, he is not doing well. This is something that you have to keep in mind. Don't say we did everything for you. You said you did everything for him. Despite that, he's not doing well. What should we do now? Inform everybody in the family, and as soon as the end happens, I will inform you. So you are instructing and you are also trying to help. If it is okay with you, I would like to say a prayer for him on behalf of all of us. So going a little extra for the patient and the family, it doesn't cost you anything. Just a sentence like that, a word like that, will really enhance the family's experience of you in their times of distress. So we have little bit more time, and now I'll come to anger in the clinic. Remember, we are not talking about a law and order situation. For example, we are not talking about a mob violence where 100 people descend on a murderous spree, or we are not talking about somebody under the influence of alcohol or other substance becoming violent with us. Those are law and order problems. We are not trained to deal with law and order problems. We are medical professionals. So, but in our day to day anger that can happen in the clinic, we need to proactively deal with it. Understand that anger is an emotion, it's a negative emotion. Unlike tears, it is a high energy consuming negative emotion. So the trick is in cutting off the energy supply, and you can easily bring down the anger fast. So we have to understand where is energy coming from. There are two ways of supplying energy to an angry person: either confronting him, arguing, or finding excuses, or even explaining or even apologizing to a very angry person may become a confrontation, depending on the intensity of anger. Another fuel supply to increase anger or sustain anger is to ignore the angry person. So if you confront or ignore, you can increase and sustain the anger. So imagine you are dealing with somebody who's becoming very abusive and loud in your clinic and directing this anger at you for no fault of yours. What do you do? As always, body language. Body language is very powerful. It is a major part of communication. So dealing with anger, body language. If you are sitting and the person is angry, most likely the angry person will be standing or pacing around, because anger produces a lot of adrenaline, and there will be so much adrenaline to be impossible for the angry person to sit down calmly and be angry. The person will be having an aggressive body stance, usually standing up, yes, and getting angry. So if you are sitting, you also stand up. Because if you continue to sit, your body language is conveying, I am superior to you. And that will increase the person's anger. When you stand up, you are showing, I see you as my equal. It's a positive body language. It will reduce the anger. Not completely, but it will contribute to reducing the anger. And when you stand, the posture is slightly kyphosis, slightly bent forward. This shows I am respectful towards you. Again, a positive body language. It will contribute to reducing. And show your hands. So you keep your hands in front. Don't hide your hands. Because in human psychology, the hands is what carries a weapon. And if you show your hands, the human psychology, the ancient brain in the human brain will give this confidence to the person that I do not intend to harm you. See my hands. You can see my hands, right? So the whole purpose of military and police and all saluting is showing the hand that I do not carry a weapon. That's the whole purpose of salute. That is where the salute comes in. So you don't have to salute, you just keep your hand in front so that you are showing that I am not aggressive. I am not a threat to you. I do not mean to harm you. So all of these things are positive body language, which are going to communicate to the psyche of the person. The person will not even realize it. Now coming to your face, eye contact. You make eye contact showing that you are confident. You are saying, I am not scared of you. Again, a very positive uh, language, body language, because eye contact shows you are confident. It also contributes because you're showing that you're not scared, it will contribute to the person getting less angry. Confidence is very, very important. Even if inside, if you're feeling scared, just pretend to be confident. The person feels that to be real. I always say smile, but in this particular situation only, I would say don't smile because smile will be seen as a threat. It will be seen as a confrontation. And in active listening, I always tell you make eye contact and nod your head because nodding your head is about encouraging the person to talk. Here, nodding your head will encourage the person to ventilate. So the whole idea is to fast forward the ventilation process of the angry person. So you are not giving any fuel to the angry person. You are neither confronting with your body language or your face. You are neither ignoring because you are confidently making eye contact and you are nodding your head. So you are not ignoring the person. You are neither confronting, neither ignoring the person. So you have cut off the fuel supply with your body language. You don't have to say a single word. So you by nodding your head, you encourage the person to ventilate, and within a short while, a few seconds, you will realize that the person's severe anger has started coming down. That does not mean the anger has gone away, but the severe anger, because that is where the danger is. When somebody is in severe anger, you never know. It is like the point of explosion. So we have to control that and bring down the anger just by these two body language, your body and your face. Once you realize that the anger is coming down, how do you realize? Earlier, there were a lot of expletives, bad words, and the volume and intensity was very high. And now the bad words are coming down. Now this person is complaining, but not using bad words. And the intensity and the volume is slowly coming down. At this point, where the high anger has been brought down to medium anger, then you can open your mouth and tell this angry person that you want to know more about this. Can we sit down somewhere and talk? So here you are extending an invitation basically to ventilate more. You are making arrangement for this person to ventilate, but you're saying, I want to know more about this. Can we sit down somewhere and talk? Don't ask somebody in severe anger to sit down because it will make the person more angry. You bring down the anger, then offer to talk to this person and offer to sit down, offer a chair. Once you have got this person sitting down, the sitting down itself will contribute to reducing the anger because the patient's body language has now changed from standing position. Now the person sits down, that sitting down will also contribute to reducing the anger. You also sit down. So now again, you are making yourself equal to the other person. And then let the person continue to talk. Whatever the complaint the person has, you make eye contact, nod your head, and continue. Find out the full story. If there is some genuine grievances and you can resolve the matter, resolve it to the best of your ability. Offer a solution only if there is a solution. Don't give false assurances. It will trigger more anger because people can understand whether you are genuine or not. If apology is really merited, do give an apology. However, if there is no case for an apology, don't give an apology just for the sake of it, just because this person got angry. Because insincere apology is easily understood, and that can make the person again angry. Or if the person is not angry, at least that person will resent your insincere apology. So if there is no case for an apology, don't have to apologize. Apologize only if you really sincerely have to. Otherwise, don't. So this is how you end it well. You can say words like, thank you for bringing this to our notice. We are very sorry you had to experience this. So there is no apology in this, but you are thanking this person for bringing it to your notice. Or, thank you for bringing this to our notice. This is what we will do. So you can tell the person, this is what you're going to do, so that something like this doesn't happen. This is the situation where you have some action plan so that uh, this kind of incident doesn't happen. If you have nothing, you can just say something like what I showed you before. We're very sorry you had to experience this. If you can do something, you can say something like that. So take home points are listen to the family to manage collusion. Your role is a facilitator of information when it comes to bad news or any news. And the patient decides how much they want to know, if they want to know. So, as far as communication of bad news is, you are only a facilitator. The patient has the deciding vote whether they want to know or not, if they want to know, how much they want to know. Ventilation of emotion is a therapy, whether it is tears or anger. Ventilation of emotion is a therapy, it is not a waste of time. Many times people think, especially doctors who are not used to these kind of techniques, they think, what is they were just sitting there. No. Allowing ventilation of emotion is a therapy. For example, if the surgeon midway during the surgery has a bleeder, sometimes they have to, if they can't cauterize it or tie it, they just put pressure on it and wait till the bleeding stops. That putting pressure and waiting is not waste of time. It is a kind of therapy. Similarly, in for emotion, ventilation is therapy. And anger, non-confrontational, active ventilation of anger. It's a very easy skill to master. So this is something that you have to understand in our day-to-day clinical anger situations. If you employ the body language, the face, the techniques, you can manage your day-to-day anger situation very well. You can prevent things getting out of control. Again, I will say this is not about dealing with law and order problem of mob violence or people under the influence. This is how you deal with people who are angry for genuine reasons or misunderstandings or whatever in your clinical environment. So with that, I come to the end of my session. Thank you for your patient listening. I'll be happy to take questions.
Thank you, Dr. Biju. Uh, So, are there any questions about today's topic? You can unmute or you can type. We can spend 2 to 5 minutes if there are any questions before moving on to case specific.
In case you have better suggestions on communicating bad news or managing pollution or managing anger, please send it to me. I'll be happy to receive them.
I'm CB from Malaysia. Yeah, just something to add on that collusion session. Normally, what I do is that I bargain with the patient, the family. I bargain with them, saying that yes, I know that you don't want me to tell your parents or whatever the patients about the real diagnosis and real situation, but I think for this, I won't able to follow what you want because I would respect the patient autonomy. So let's come with an agreement that if patient asks me about what is his or her condition, then I'm going to expose all the information to the patient. But if the patient not telling me, then I respect the family. I will say, okay, so I won't disclose anything. So normally I do that lah. So but most of the time, the parents know that this is my stand. I won't actually join them to so-called cheat the patient. Yeah. Sometimes they expect us to cheat the patient, say that, oh, you are going to recover. Then they give a false hope for the patients.
Thank you for that, CY. That's quite a different way of dealing with it. I personally wouldn't call it cheating, because when I will speak from the Indian perspective, if we tell the patient, the family can get very, very aggressive. And that is not good for us. So idea is to have the family be on your side when you tell this to the patient. Sometimes what happens, the patient wants to know, the family does not want the patient to be told. And now we are caught in the middle, right? So I usually, what I tell the patient is, I need more information before, and then I'll get back to you. Which, is it telling the lie to the patient? I know the medical condition, I know the diagnosis, prognosis, but what I really don't know is whether his family will agree to convey the truth to him. So that is also part of information I need. That information I don't have, whether the family will in future agree. So in that sense, I am really not being untruthful to the patient. So I buy some time with the patient. Then again, I go back to the family. I try to counsel them. And again, as I said, over a period of time, our ability to reorient them improves, because the idea is how you are going to put them in a situation where they are no longer able to give back answers as to why it is better not to tell. So they will eventually come to a situation, okay, I understand, you tell it to the patient. So all of these things has to be considered. The problem is, if the patient wants to know, the family says, don't tell, you end up going and telling it to the patient. At least I know in the Indian context, the family is going to give us hell. They may at best take us to court, or most likely they are going to beat us up for doing things against their wishes, telling them despite we telling you not to tell. So I don't know how it happens in Malaysia, but in India, I would be very, very scared to tell the patient against the wishes of the family.
Yeah, we are
Does that
almost the
happen in
same when they
Malaysia?
said. Yeah, we are almost the same when they say don't tell my mother whatever. So actually we are not pushing to say no, I must tell, but I would bargain saying that if your parents or the patient ask me, so as a doctor I'm going to tell. So if the patient asks me, means that the patient wants to know, and this is the patient's right to know. With that, they respect most of the time. So actually, after a few sessions, they will actually ask the doctor, say, do you mind to hint the patient so that to start the conversation, because they feel, I mean, like what you said, they build the trust with us. We settle the symptoms, so they found that actually we can actually help to enclose the informations. Yeah.
Okay. Thank you for that, Sivi.
Thank you, Dr. C.
And nice meeting you.
There is another question in the chat. According to your experience, what type of patients are more like, do they want to know or don't want to know? Which type you see most of?
Mostly people want to know.
I think there is a study and publication.
Yeah, please,
Yeah,
please.
where they have interviewed 10 patients. 9 out of 10 patients wanted to know. I think it's done by Dr. Naveen in Indian context, that 9 out of 10 wanted to know actually about it, but then either their loved ones or their doctors were not ready to talk to them.
Yeah, the communication opportunity never happens, or most of.
Sir, there is a question, what if the patient is in denial, not accepting the diagnosis? How can we go about it?
That's a good question. So to start, my opening statement would be, denial is a psychological coping mechanism to a potentially emotionally traumatic experience. In simple words, denial is like a shield. It protects you from the realities of life. In that sense, denial is fine. It is a shield. It protects the psyche of the individual. So I will not be going around destroying denial just because denial exists. However, if denial is becoming a barrier to an intervention or treatment, which is evidence-based, which is beneficial to the patient, in that case, I will try to uh, get through the patient's denial, only if it is going to help the patient. Otherwise, I'm perfectly fine with the patient being in denial, because there are patients who say, I don't have a problem. You give them the medicine, they will take the medicine, even though they say, I have no problem. So those kind of situation, the denial for them is like a psychological crutches with which they can have their journey. Feel free to add anything, Sri Devi, or
No, sir.
any of the audience.
Dr. Shivakumar asked that question. Dr. Shivakumar, is that the answer is okay for you, or you want to ask or add on to that?
No, sir. Good evening, sir.
Good evening. Good evening.
But if the patient has some last wills or something, if he has to do, but he's not accepting our diagnosis, then suddenly if he dies one day without any this thing, then it won't be any problems.
I didn't understand your question. Can you just
A
give
patient. So suppose patient comes like terminally, like CS stomach, with a terminal illness, when it's about to obstruction or something like that, sir.
Okay.
And we are telling that it is a cancer and it's terminal, you have to get operated or something. And he's telling, no, it's like a simple thing and I don't want, I want to see another doctor or something like that, sir.
To begin with, I wouldn't suggest operating a terminally ill patient, but probably that's not what you meant. The thing is
no,
that,
sir, it's not only for surgery, sir.
Understood.
It's not for surgery. And he is not seeing any doctors and he's going back home, and suddenly one day he dies. But he doesn't know the severity of what, he might die in a few days or in a few months. And for his family, he thinks that it's not like a simple thing and we might leave for something, and some last wishes or something he's not giving to them. So in that case, whether we can bypass the patient and go and tell the family attenders, or is it, I mean, just leave it like that?
Shivkumar, in our environment, in the Indian context, anyway, we discuss the bad news, we discuss all the information with the family, right? So it is,
Yes.
the problem is we have to get the family on our side so that we can convey the same information to the patient. In our context, that is the biggest challenge. That anyway, the family is informed by us. So they themselves decide how to proceed and all. The patient just goes along. However, I take your point. If the patient says, no, 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 I don't have any such problems, but forget about dying and terminal illness.
Yes, sir.
Let's say he has a medical condition for which a treatment exists, which will make him well, or at least get him out of a dangerous situation. Then, then of course, the family can try to influence the patient, try to break his denial, and along with it, I would also try to convince him. When I say breaking denial, it is not a violent act. It is basically sitting and trying to understand why this person is in denial, what are his or her thoughts, what are his or her understanding, insight over the matter, what are his or her concerns and fears related to it, and then trying to get the person out of denial. I would be doing all of that only if the person is going to benefit out of the intervention we are trying to do, and the denial is becoming a barrier. In that case, yes, I would use my counseling efforts and techniques to get him out of denial. Otherwise, I don't have a problem with people being in denial for something. That's fine.
Thank you, sir.
Does that help, Shivkumar? Does that make
Yes, sir.
sense?
Yes, sir. Yes.
I want all
Thank
of you to understand that denial is not bad. Denial is just a psychological mechanism. It's like a protective mechanism which people, which human beings use as a psychological shield to protect themselves from traumatic emotional experience. So as long as it is not becoming a barrier to treatment or things that the patient is going to be benefited by, let the person carry the barrier, carry the denial for some time. Problems? No. Communication is a team sport. And within communication, there is a triaging system. Majority, for each person, for majority of the patient that they see, they will be comforted with first aid communication. First aid communication, good body language. For some patients, you need elective intervention, communicating bad news, collusion management. You need some time. You need to take out some time. In certain situations, you need emergency communication, like managing anger. So when you're dealing with uh, in a high stress situation like ICU or emergency, where a lot of things are happening, it's a very fluid situation, a very dynamic situation. Don't think that only one person is responsible for communication. The doctors, nurses, social workers, security, everybody. We all need to be good. We all need to be trained in communication so that each one of us can enhance each other. It's not just that only the doctor should go and communicate to the family member about what is happening. Once the doctor can go, the second time the nurse can go and update. Third time the social worker can go and update. It's a team sport. Communication is always a team sport. It is not an individual sport. Sridevi, comments?
Thank you, sir. Nothing more to add.
You agree with the
Sri-
team sport analogy?
Yes, definitely, sir. Even in the busy OPD, not just in the emergency department. And as you mentioned, in COVID situations where one doctor is catering to so many different patients, it's really important to take the advantage of the team. And it's really important to train your team members to deal with these situations than just putting them across.
Yeah.
It's important to prepare them for these kind of skills.
Exactly. Once you get sensitized to the importance of communication, then you will realize that you need to turn your entire staff into good communicators. Don't carry the whole burden on your head. It is not your cross to bear. Distribute the work. That is, the whole idea of good communication is it should make your life comfortable, peaceful, and you get the most out of the time you put in. Good communication means no hard work, smart work.
Thank you, sir. Shripriya, can we start the case presentation? And then there are a few questions, but I will take it in.
I'm sharing the screen.
Dr. Shirley?
Yes, ma'am. My patient is Mr. A, age 50 years, with squamous cell carcinoma of the left gingivo-buccal sulcus, with recurrence and metastasis to lung, the skull, cervical vertebrae, and larynx. He presented to us with a 1-day history of unable to swallow even saliva, 4 days history of unable to chew and swallow food. There was a growth on the skin of his neck in the front for 2 weeks. There was pain at the back of the head over the left side of his ear head for a month. And he has been having fatigue, weakness, and increasing hoarseness of voice for about 2 months now. He was diagnosed with carcinoma, lower gingivo-buccal sulcus on the left side. Last year in April, May, he was treated for it with surgery, radiation, and chemotherapy. He was symptom-free for about 5 months post-operative period. Since the last 2 months, he's been feeling quite fatigued. He's not been able to move around much. He is housebound. In fact, he's a bit bedridden. He has increasing breathlessness and pain in his neck, ear, head, everywhere. He also has a growth which is in the front of the neck, which is ulcerating. It is painful, and it is increasing in size over the past 2 weeks. The pain is deep-seated, bony sort of pain over the left temporoparietal area, all around the ear, the nape of the neck, and he's having recent onset of throat pain, unable to chew food and eat since about 4 days, and 1-day history of unable to even swallow saliva. Next, please. He was diagnosed with CA of the gingivo-buccal sulcus, T3 stage, N2, no mets. Cervical nodes level 2 were involved. He underwent composite resection of the left hemimandible with a modified radical neck dissection with the PMMC free flap reconstruction last year in June. And he has received adjuvant chemotherapy with carboplatin, paclitaxel, etc. 11 cycles, the last one in December. And that was the last cycle because they discovered that he was not responding much to treatment. and he had started to have a lung metastasis. So they stopped with the 11th cycle. On examination, he was quite emaciated, quite cachexic and afebrile. Pulse, BP was okay. And right lung lower zone, there were decreased breath sounds. In the front of the neck, there was a ulcerative growth just above the thyroid cartilage, everted edges, bleeding on touch. There was induration all around. It was quite painful. And inside the oral cavity, there was a whitish patch on the left gingiva buccal sulcus in the area where the previous tumor was, meaning it had recurred. And there were also a lot of other whitish patches which were bleeding on removal, adherent to the mucosa, and there were a lot of oral secretions. Basically, he had extensive oral candidiasis, probably which was extending into the esophagus, which is why he was not able to swallow even his saliva, and everything was just pooling in the posterior pharynx area. Next, please, ma'am. His investigations, hemoglobin was 9, total counts were decreased. And the CT thorax, which was done last year in October, revealed lung metastasis with moderate pleural effusion and right lower lobe collapse with consolidation. The ulcer daily dressing was done, but it was progressive and it was proliferating. The exact extent and the depth of the ulcer was not known. It's probably a recurrence, and it would need a CT scan with contrast to be done to ensure the extent of the growth. And oral candidiasis was observed, which is why he could not swallow food. So we had placed a nasogastric tube for feeding purposes. And for his pain, we started on tablet paracetamol and tramadol round the clock. He was taking morphine, sustained release, 30 milligram at bedtime. And with that, he was able to sleep well. It would last for about 10-12 hours. So we also gave him tablet morphine 5 milligram to take on an SOS basis. And for the candidiasis, fluconazole and candid mouth paint were also given. Next, ma'am. Psychosocial aspects, he lives in a joint family with his brother. Actually, his care is overseen by his younger brother, his son, and his nephew, because they were the ones who accompanied him for all the treatment to the nearby district hospital, which is about 60 kilometers from here. They are a middle-class family, and so far they have been able to finance their treatment. And they were told by their treating doctor that he's in the terminal stage and they cannot continue much. So the chemotherapy was stopped with the last session. But they did not tell the patient what is happening. They have not told him the exact extent of his disease. And even when the son was narrating to us the exact events which had happened, he told us to move his father out of the room, and then he told us about it. And at home, it's his daughter and wife who are actual caretakers, but they did not accompany the patient for any of the hospital visits, and neither are they informed about the prognosis or the extent and severity of the disease. The patient is not able to speak much because of the hoarseness of voice and throat pain, probably because the tumor has progressed and maybe it is involving the vocal cords, which is why he's having progressive hoarseness of voice and is unable to speak much. Next, ma'am. So his main concern now is how to give him pain relief. And the ulcerating wound is spreading to the larynx. We do not know exactly how much deep it is. And his inability of oral intake, which we have been able to give palliative relief with the Ryle's tube feeding. So to summarize, he is a 50-year-old man with locally metastatic ulcerative squamous cell carcinoma of the gingiva buccal sulcus and metastasis to the lung and skull, now with oral and esophageal candidiasis. So our main concern was how do we provide him adequate pain relief? And how to ensure that he has a peaceful and a comfortable passing away. And more than that, how to counsel his relatives to involve their family, especially their immediate family, and to explain to them his actual condition, and so that they would be better prepared for dealing with it.
Thank you, Dr. Shirley. So I understand there are questions about pain relief also, and there would be definitely some comments that we would want to make on the current medication pattern. But for today's discussion purpose, I am trying to focus more on the third question. And I can send you the suggestions on prescriptions to your number or through your email. But for today's purpose, multiple caretakers come to hospital, usually the male members of the family, and the female caregivers will be at home, knowing, taking care of them first standard, and then not knowing what is happening. So in that background, how to go ahead, go about dealing with such communication?
It is true that is a very normal situation that we face day after day. Most of the time, when you ask people why you are not telling uh, the others in the family, in this case, the ladies in the family, most often they will say we are trying to protect them from emotional harm. Uh, in, and so usually I'll ask them, so they don't know and they are not expecting something bad will happen. So what will happen if when he dies, wouldn't that be a shocking experience for them? Wouldn't they be traumatized because they never got a chance to learn to cope with the bad news? You have this advantage, you know about this. Probably you cried alone, but at least you have some time with which you have come to terms with the situation. They have not been told, and we are denying them the time which is required to cope up on hearing a bad news. What will happen if they have some permanent emotional injury when something terrible happens? This, I'm not saying this is the only way you can deal with this, but I'm saying that when I say something like that, it makes people think. At least they start thinking. And then I can kind of guide them on why it is important to speak the truth. So here I'm not talking advocating about communicating bad news to the patient. I'm advocating letting others in the family who have been denied the information, full information, partial information, whatever it is, to be told. And there is an advantage in being told. That is, they get time to cope up with the bad news. So that's my short take on it.
So what if just elaborating upon that aspect? What if there are multiple caregivers coming in and going? I mean, decision makers.
Understood. Okay, I understood. Yeah. So here, this calls for what do you call an extended family counseling session. Was that what you were leading to, Sridevi?
Yes, sir, because the people spending money will be different and people taking care of the patient will be different. So
Understood. So I would kind of uh, will try to persuade the extended family. Before COVID, I could get people physically to visit me in my OPD and sit and I could talk to everybody. But in COVID times, we are now resorting to telemedicine or WhatsApp or something like video chatting, various Zoom video chatting, where we can connect to various members of the family so that everybody can be brought to the same page about what is going on, what is the situation. And then it gives a chance for people to ask questions, and others in the family can hear what one person is asking. Sometimes I just need to facilitate a family discussion. Many times others in the family will give the answer. I may sometimes have to give some additional information. So it is, the whole idea is to have a family session so that everybody comes on the same page, and also have an idea of what is possible, what is not possible, and how are we going to go about it. So varying different people pulling at different directions can be avoided. We can have a focused care plan for the patient, all the family members understanding what is going on and cooperating with it. Does that help, Sridevi? Is that what
Yes.
you were
Thank you.
aiming at? Okay.
Yeah, yes, sir. Dr. Shirley, you have
Yes, ma'am.
some more question in how to communicate with their family and reveal them about the actual situation. Dr. Biju was mentioning about the family meeting. Um, do you have any other questions regarding that?
No, ma'am, we tried to tell the family, whoever, all the male relatives who had come, because the patient was in a terminal stage at that point. But they were not very convinced, they were not willing to listen. And 2 days later, they brought the patient. He was actually in shock, in hypovolemic shock, because he hadn't taken anything orally. And even at that point, when we counsel them to take a separate room and keep the patient there, they were very aggressive. They wanted ICU treatment. So we just had to stabilize the patient with fluids and some vasopressors. And once he was stable, we shifted him to to a private room and told them that he needs to have his family around so that they can have a chance to say goodbye to him. They can talk to him. But because it's COVID situation and only the immediate family members were allowed, but still we allowed all of them, whoever he wanted, his children, to come and to talk and spend time with him. Even then, we did advise them that they can take him home so that all of the family, everybody can have a chance to be with him. But they were not willing to take any of it. They wanted hospital management only. Unfortunately, he passed away yesterday. So that was the
Thank you for sharing that. I think Dr. Biju, even we both agree that even if we try the best of our communication skills, there are some situations where we might have done a good job from our side, but there are some situations where uh, we may not reach where we want to reach because of the lack of time. Maybe the patient come to us in a very last, very terminal stage that you don't get enough time to have, even to develop rapport with the patient and the family. Sir, any last points to add on to that?
It is true that things may not go as we would have wished them to. The only thing in our hand is to try to the best of our ability. There is no shame in failure. The only shame is not trying. The only shame is in not trying to improve ourselves. So just keep up the good work, continue the learning process. You all are accomplished practitioners of your craft. Now you have come to learn palliative care. Just add the principles and practices of palliative care into your repertoire, and we'll together try to make this world a better place. Just keep try. Failures will be there. Who doesn't fail? No shame in failing. Keep on trying. Keep up the good work.
Excuse me, sir.
Yes, please.
Sir, I still have a dilemma, like over the point that is it even if people come to know at the very last stage that something is terribly wrong with the relatives, they eventually come to accept it. So, what is the point of telling them these things quite in advance? Because I feel that those who are closely related with the patient, they die every moment with the patient. So I do not have much experience in this, but I want to
I think we lost Dr.
can we
Shweta.
tell.
Yes. I think we lost the connection.
Sir, could I make my point clear?
No, I'm sorry. We lost you.
Okay.
Could you?
Sir, I'll repeat my question. I
Yes.
want to know the rationale of explaining things far in advance to the patient's relatives, because sometimes when patient's relative realize that they have a person in the terminal stage, even they die every moment with the patient. The emotional links are so strong. While if even if they realize it at the last stage, even eventually, then also they accept it. So, in which case, like, do you think the emotional trauma is more if they learn it at a very later stage, or if we inform them far in advance?
Whether it is the patient or the family, whenever, or you or me, when we are to know that something is wrong with us, it is normal human psychology to feel emotional about it. How you express emotion can vary from person to person. Some people may just sit with their hand on the head. Some people may cry. Some people may get angry. It could be different. So as long as you are a human being, we will react emotionally to a bad news. Now, after we have heard the bad news, we may go into denial. We may go into bargaining mode. I'll do this, then can I get better? If I go there, can I get better? If I spend some money, can I get better? Or will my loved one better? We can go into an angry mode. You people, this, that, we may get angry at the doctor, at the institution, at the relatives, angry at myself. We may go into depression. Everything is lost. Eventually, it's possible that we may come to a state of acceptance. So all of this will require time. And when time is in short supply, it is best to know as early as possible. Because if we know at very late, we don't have time to cope up with all that is happening. So it is like you are given time to mentally prepare yourself for something bad that will eventually happen. Does that make sense?
Yes, sir. Thank you, sir.
Thank you.
Thank you, sir. I think we can wind up today's session. There was one question which I couldn't take up because of the lack of time, which I have sent to you as email. If you can just put in your comments,
No, we have anyway exceeded time. We might as well take that question.
Okay, so that's a very long question. How can we console patients who are not able to cope with their with their diagnosis, especially young patients who got sick all of a sudden and who are filled with questions of why me? So how can we provide them realistic hopes?
Right. Now, seeing is believing. So I think the best remedy to that answer is to attach yourself to a palliative care center and be part of the daily activities for some days and see how your average palliative care practitioners are dealing with terminally ill patients. There is nothing called a hopeless situation because there is always some realistic hope you can give. This I learned after coming into palliative care. Otherwise, I was also under the impression if you can't treat, it is a hopeless situation. There is nothing called as a hopeless situation. So you have to see how these things are done. I can sit and talk 1 hour and it's not going to make an impact. This is a question which requires what we call bedside teaching. It's like something like that. This kind of communication interaction, when you see, then you realize it is possible. And there was one statement, the last slide, in which written comfort and how can we give comfortable and peaceful death. I want all of you who is listening here, please remember, in palliative medicine, we are not in the business of giving peaceful and comfortable death. That is the business of advocates of euthanasia, peaceful and comfortable death. Palliative medicine is in the business of providing peaceful and comfortable life till the point of natural death. We are in the business of peaceful and comfortable life. We are not giving anything to anybody to give them death. Focus is on life. Palliative care is focused on life, not on death. Sridevi.
I think Dr. Alma asked that question and you answered it really well. Dr. Alma, was your question answered?
Yes, ma'am.
Thank you. Thank you.
Really? Are you sure?
I think we'll have to see more patients and deal with them. Then only we can know about it more.
True.
Yeah, true.
There is only so much you can learn in a online program.
Yeah.
Offline sessions, when you go through those kind of things, real life bedside learning, you'll see that these things are possible. Yeah. All the best.
Thank you, sir. And thank you everyone for bearing with us for this extra time. And we had a very good questions and answers and very good discussion actually.
Very
So thank you so much for your interaction. Thank you so much, sir.
Thank
for
you.
being with us.
Thank you for the
Thank you
nice
so much,
compliments.
Biju Raghavan sir, for your time. And thank you everyone for joining in. And so with that note that palliative care is all about life and life only, we are signing off. This is Sripriya signing off along with Dr. Sridevi and Dr. Biju Raghavan. See you in the next session. Till then, everyone take care. Bye-bye.